Yes, ma'am.
Okay. So for parathyroid glands, well, anatomy, not interesting for us. Histological oxyphil cells, parathyroid hormone produced in parathyroid glands, it plays important role in reabsorption of calcium from bones, from urine, and also its absorption from GAT. It also increases excretion of phosphate. Calcium, it's a macro element. It plays the important role in our body in all metabolic processes, especially in muscle construction and nerve impulse regulation, nerve conduction. And also calcium is important for clotting. It's one of the clotting factor. It's important for secretion of enzymes in GIT and hormones in endocrine organs. So everywhere you may find two types of calcium in our body: ionizated calcium, so calcium with which is free without any albumin. It's not transported by albumin. It is a free pure calcium ions in organism, in the blood, and we call this calcium ionizated calcium. 50% of calcium is connected with albumin. This calcium is called total calcium, and it is not active. It just stay in blood for need of the body in situations when the level of ionizated calcium decreased. That's why, if you look at this slide, you will see that nearly one calcium present in our bones, in the whole body, in adult person, of course, nearly half kg of calcium present in other tissues like muscles, nerves, GIT, skin, hairs, nails, etc. So calcium is very important, first of all, for regulation of muscle and nerve system. We need to understand the difference between free calcium, circulating this free ionizated circulating calcium, and calcium which is circulated with albumin, because when you prescribe examination of calcium to laboratory, so when you give the recipe, when you write by your hand, so you write by your hand this prescription, usually people, they do not have medical education. I mean your patients, and they don't know this prescription is correct or not, and they show that receipt to laboratory, and of course laboratory will do what you ask. So if you don't know that difference in various types of calcium, you may not understand the problem if it's present. If there is a problem with calcium, if there is calcium disbalance, it will be difficult for you to understand what happened. So that's why better to check ionizated calcium, means free calcium in blood. If your laboratory in the area where you will practice does not do that examination, you may check albumin level, you may check total serum calcium in blood, and according to this formula, recalculate the level of ionizated or free calcium. But we are in endocrinology, so we are interested today in the two diseases which connected with our profession. So with my profession, with profession of my colleagues who will also also your teachers. And these are pathology of parathyroid glands. We know many various pathologies of parathyroid glands, but now the level of sixth semester, you should understand just the difference between hyperparathyroidisms, various types of this condition, and low-level hypoparathyroidism. To understand this, if you do not know normal physiology of vitamin D, PTH, and calcitonin metabolism, it will be very difficult for you to understand the difference between that pathologies. So vitamin D, it's a very important vitamin. It regulates also together with PTH, calcium deposition, and the type of vitamin D which present on this or that organ. We have two resources of vitamin D. It is the sunlight. As I said yesterday, sunlight is very effective in secretion of vitamin D, but only in people who have light skin and who live in the south areas, but with light skin. In our country, in North countries, in European, North America, Russia, etc., in that countries where we have winter time with the snow and short day periods. Unfortunately, we do not have enough vitamin D and enough because of enough sun. But there is another problem that we usually we wake up in the early morning and then go for our walk. Then we or maybe our university, then stay in the close rooms all day, and then in the evening time come back home. So even if we have enough sun, because of our way of life, we don't have opportunity to stay on the sunlight enough time. And we need at least 20 minutes of sunlight for normal every day for normal secretion of vitamin D. But there is another resource of vitamin D. It is a dietary resources. It is a fat fish, especially salmon and trout, and it is milk and cheese, of course. But in fish, level of vitamin D is highest among all other products. So, and that's why we can take vitamin D in supplements. What we usually do, we add supplements with vitamin D in our nutrition. Then vitamin D, if it is taken from diet, it is not active. It is activated in liver. Active, and in our skin, it is not active. It is activated in so skin vitamin D needs to be activated in liver. Dietary vitamin D is already active D2 usually, active vitamin D. So that's why pay attention on the supplements. If you take them, if it is written that it is D3, it will be converted to active form in liver. If it is already D2, ergocalciferol, it is just will be to the organs without conversion in liver. No difference anyway. Liver will try to convert it if it is healthy. So health liver will convert vitamin D to 125 hydroxycholecalciferol. It's another name of this vitamin D is calcitriol, and activated its receptors in kidneys, bones, GAT, and parathyroid gland. So everywhere there are receptors to vitamin D in target organs. In intestines, there are also receptors to vitamin D because vitamin D, as I said, just plays an important role in the absorption of calcium. Then, once again, look at the up part of this picture. Calcitonin, it's a hormone of thyroid gland, C cells. Thyroid gland produces 3 types of hormones, follicular cells, or we also call them A cells, they produce T4 and T3. C cells, easy to remember, C means calcitonin. Parafollicular cells, another name of their cells, they produce calcitonin, which stimulates calcium deposition in bones and reduce calcium uptake in kidneys. Parathyroid hormone, the down part, look, what does it do? It's I like this scheme. It's very easy, but help you to understand pathology. It increases calcium uptake in intestines, increases calcium uptake in kidneys, and stimulates calcium release from the bones. So what does it mean? If person has too much PTH, these all processes will be increased, will be very active. Calcium uptake in intestines, increased calcium uptake in kidneys, stimulation of calcium release from bones will be very intensive. Normally, everything in balance. When level of calcium increased, PTH level become low. And opposite, if we eat less calcium, our parathyroid gland produce more PTH and process becomes more active. That is, all changes in hormones, in PTH and in calcitonin depend on calcium level in blood. And vitamin D also level in blood. So this gland, parathyroid gland, and calcitonin does not depend on pituitary. Absolutely, there is no dependence on pituitary. We have 3 organs, endocrine organs, which are not dependent on pituitary gland. Pancreas, so because insulin and glucagon secretion, they don't depend, they produce by themselves. So pancreas regulates secretion of these 2 hormones according to the also positive and negative feedback effect during receptors connection with glucose in pancreas and peripheral tissues. Here is same situation. PTH secretion and calcitonin secretion does not depend on pituitary, and mostly it's produced by help of due to the regulation and changing of the levels of calcium and vitamin D in blood. And third organ, it is an adrenal cortex and medulla, but not all the part of adrenal glands. Next lecture I will tell you. Aldosterone renin system regulation also doesn't depend on pituitary. So also, I think yesterday you made a screenshot of this slide. What happens if level of calcium increase? It stimulates secretion of calcitonin. If calcium in blood decrease, here is this first picture shows you low blood. Look at the left part. Low blood calcium stimulates production of PTH, and it activates 3 tissues: bone, kidney, and intestine. Calcium released to blood. Look, arrow back, negative feedback effect. Parathyroid gland understands that calcium in blood becomes normal and decreased PTH level. Look at the left. If calcium in blood is high, if it is high, it may happen when, in what situations? If we eat too much calcium products, it also may happen in some cancer disorders, malignancies, especially malignancy of bones with the bone destruction, Paget disease. It is also bone disorders. I don't know, did you have already hematology classes? Maybe you discussed the myeloma disease also may happen. Metastatic disease of bones stimulate elevation of calcium in the blood. It's this, of course, a pathology of the body. In normal, in health people, it may happen if we eat too much calcium. For example, we eat every day sesame seeds or every day a lot of dairy products. In this situation, parathyroid gland produces less PTH. You see everything crossing, and kidney, bones, and intestine receptors they are not active without PTH. Level of calcium in blood normalized. It becomes normal. It's a normal regulation, normal parathyroid function regulation. So we have 2 disorders, as I said, hypercalcemia and hypocalcemia. Hypercalcemia, if serum calcium, total serum calcium more than 10. Hypocalcemia, if it is less, ionized calcium, if it is more than 10. Hypocalcemia, if ionized calcium less than 8.5 mg. And the first disease is hyperparathyroidism. High level of PTH. Everything connected with parathyroid gland. We will not discuss today other pathologies of calcium metabolism, the other causes of hypercalcemia. It's not my topic for today. It's a very big lecture, but there are a lot of types of hypercalcemia due to the other reasons except parathyroid gland disorders. But we should understand only parathyroid gland disorders according to my course. Course of endocrinology classes. Hyperparathyroidism, 3 most common endocrine, it's the 3rd most common endocrine disease after diabetes and thyroid disorders. excessive secretion of parathyroid hormone. But here we will have one problem. I mean, you will have one problem, how to understand what's the difference between primary, secondary, and tertiary form. Look, HPT, it's hyperparathyroidism, can be characterized into primary, secondary, and tertiary. Big problem to understand what's the difference, because treatment will be different. Primary hyperparathyroidism. It's a tumor or hyperplasia of parathyroid gland. Parathyroid gland produces too much PTH. If you hear hyperparathyroidism, means that PTH is high. It could not be low. If it is low, it is hypopara. But hyperparathyroidism, PTH is high. Then, but calcium and vitamin D and phosphorus is different, depend on the cause. Primary hyperparathyroidism, it is a tumor of parathyroid gland. Secondary hyperparathyroidism, there is no problem in parathyroid gland by itself, but there is a problem in calcium level. When it may happen? When level of calcium decreased or level of vitamin D decreased. When it may happen? The most classical reason is a chronic kidney failure. Chronic kidney failure, the first reason of low vitamin D and calcium level all over the world. Second reason is malnutrition, especially among people who are vegetarians. So among Indian and other South Asia countries like Bangladesh, Pakistan, Malaysia, if you know that there are areas even in India where many people are vegetarians, plus to this, especially in South India, have a really dark skin, they have the percent of vitamin D deficiency is really very high. And this may provoke hyperparathyroidism, but it is not primary because there is no tumor. It is just a, so this is the situation when parathyroid gland, so when the level of parathyroid of calcium and vitamin D decreased in the body, parathyroid gland produces more PTH to overload that situation, to overload this moment, these metabolic changes, because without constant concentration of the calcium in the blood, we will not have normal heart constriction. So level of PTH increased according to these two causes: kidney failure and malnutrition or poor vitamin D supplementation in various categories of people. So this is secondary. Secondary hyperparathyroidism may convert to tertiary, because tertiary hyperparathyroidism, it becomes a big problem. This is the combination actually of secondary and primary, because if people have prolonged deficiency of calcium and vitamin D, parathyroid gland produces too much PTH for a long time. Parathyroid gland becomes less sensitive to vitamin D and calcium and formates tumor in its cells. So tertiary hyperparathyroidism, it is a formation of hyperplasia and tumor in parathyroid gland after prolonged secondary hyperparathyroidism. So once again, secondary hyperparathyroidism and tertiary hyperparathyroidism, it is autonomous parathyroid function on the top of parathyroid hyperplasia usually after secondary hyperparathyroidism. Now I will speak about primary, because primary hyperparathyroidism, it's our endocrine disease. You will ask, why not secondary? Because with secondary hyperparathyroidism should work mostly nephrologists. This is their topic, especially people who are on dialysis stage, people who have hemodialysis, they should control their calcium and vitamin D level, because patients on dialysis, they have a very high, not percent, very high chance of formation of parathyroid hyperplasia because of secondary hyperthyroidism. So primary, usually it is a single adenoma, 80% of cases. Normal parathyroid tissues around the adenoma distinguished adenoma from hyperplasia. Hyperplasia, what's the difference? Histologically, it is different. Adenoma, in adenoma present, histologically present nodules. If it is just hyperplasia, it is enlargement of parathyroid cells without nodules. So hyperplasia, 15 to 20% of cases. Usually, if it is hyperplasia, all 4 glands are involved. And in most cases, these tumors are benign tumors. In the parathyroid carcinomas, they may present only in 1% of cases, but it is also possible to see sometimes malignancy. So parathyroid carcinomas usually very classical in the clinical picture and need quickly treatment. That is also I wanted to understand that endocrine tumors, if you see an endocrine in person with any endocrine tumor, a tumor of pancreas which produce hormones, because in pancreas may present 2 types of tumors, in exocrine and endocrine cells. If you see tumor from endocrine cells which produce insulin or glucagon, or sometimes somatostatin, depending, so remember please, histology and anatomy. Please, to practice classes, repeat once again anatomy and histology of the organs of endocrine cells, endocrine tissues. So if you remember that there are many endocrine cells in our body, many endocrine organs, if it is tumor in one of the organ, if it is tumor, for example, in parathyroid gland, as I say, tumor in pancreas, tumor in pituitary gland, tumor in ovary or testicle or adrenal glands, we always should exclude presence of the tumors in the other cells, in the other organs, because there are 2 types of syndromes, which we called well, actually, there are 4 types of syndromes, but more classical to see these 2 types. Multiplying endocrine neoplastic syndrome and parathyroid tumors have a strong connection with these syndromes. So look, multiplying means many endocrine organs are involved in this pathology. Parathyroid adenomas. They have earlier manifestation. If it is in syndrome, it's a genetic syndrome. It's a changing of genes. We know what type of genes already found. This genes usually started in a young age, in the first decade of life, and MAN2 syndrome, it usually started in second or third decade of life, so between 20 to 30 years old. Look what presents here. It's a parathyroid adenoma, pituitary may be adenomas, and pancreatic cells adenomas. In MAN2 may present parathyroid adenoma, thyroid cancer, and pheochromocytoma. It's a tumor from adrenal glands. So if I have time today, I will speak a little bit about this tumor. PTH produced in primary hyperparathyroidism in high level. So high level of PTH stimulates. What does it do? It stimulates, of course, elevation of calcium in blood. So look, you will see 2 changes: PTH elevation and calcium level elevation. Classical symptoms include, with the red color, kidney stones, pain in bones, abdominal changes, pain, psychiatric changes, and abnormalities in urine, as hypercalcemia provoke hypercalciuria and polyuria and polydipsia. So what we will see, because the level of PTH is high, what does it do with the bones? It will remove calcium from bones. The pictures will show you severe osteoporosis, bone resorption present. Sometimes if level of PTH is very high, resorption will be critical. It is osteoporosis transformed to osteomalacia. we call this deposition that there is a specific change in bones due to the hyperparathyroidism. It is called brown tumor, but it is not a tumor, absolutely. It's just a name of this symptom. On X-ray, we see such changes. Look at the picture, how thin the bone tissue is here. That is the influence of PTH due to the tumor. On the areas of bones, accumulated fibrotic tissues and formatted such formatted new vessels and deposition of cells. Then, that is other symptoms. What do they include? Skeletal osseosis, or bone resorption, diffuse osteoporosis, bone softening, periostitis, arthritis, calcinosis, but of soft tissues, visceral calcification, this calcium, because so it's removed from the bones, but in blood, calcium level is high, so calcium will accumulate in the tissues where it should not present, usually in soft tissues. Another clinical symptoms include renal stones, kidney stones. It's a very classical symptom. If you see, next year you will have urology classes. If you see a repeating of kidney stones in one person more than 2 times in life, you need to check parathyroid gland activity and to exclude presence of hyperplasia in this gland. Gastrointestinal symptoms include anorexia, nausea, vomiting, hypomotility of bones, constipation, pancreatitis, peptic ulcer disease. It's all because of the hypercalcemia, because this calcium accumulated in soft tissues of the body and in mucous cells also. It stimulates formation of ulcers. Muscle weakness, bone pain, osteopenia, osteoporosis, neurological, decreased concentration, fatigue. Sometimes in severe cases, if it is hypercalcemic crisis, next slide I will show you, may provoke coma. Of course, cardiovascular changes. Also, another photos of patients with hyperparathyroidism. So, bone resorption, severe bone resorption. In emergency, there is one emergency situation in this condition. It is called hypercalcemic crisis. Patients with primary hyperparathyroidism may have, if level of calcium increase more than 10, we may see if ionized calcium increase more than 14 actually. People will have hypercalcemic crisis. It's nausea with more vomiting, nausea, fatigue, muscle weakness, confusion, desorientation, and chronic and renal failure. So what we should do here, unfortunately, only hemodialysis. So hypercalcemic crisis mostly present in people with parathyroid. Want to see if it is malignant tumor. So what we will use for diagnosis, please. Of this, you see all changes which will present in primary hyperparathyroidism. What we need to check, serum tests include, of course, PTH level. It will be high, classical changing, high PTH. Then phosphate level, usually decreased or low normal. Calcium level, high. Alkaline phosphatase increased. It shows us destruction of the bones. Calcium in urine increased. Urine test also should be performed because you must understand what's the reason of this hypercalcemia. Maybe it is a renal failure, and this is not primary, it is secondary. Creatinine level, it could be normal, could be low, various types, but you need to check it. Then, also please differentiate diagnosis, make a screenshot of this slide. or in practice, we'll discuss what to do and how to do differential diagnosis. There are 3 types of hyperparathyroidism, of primary hyperparathyroidism. It could be classic, with the high PTH and high calcium, could be normal calcemic, and normal hormonal primary hyperparathyroidism. You see, that topic is, as I said, it is a difficult one in understanding that difference between various types. Then what we should do, how we need to see where is a tumor. In this, we will do scintigraphy test. Ultrasound examination, unfortunately, is not sensitive for diagnosis of parathyroid gland tumors. Better to do systemic B or MIBI scintigraphy, the name of the drugs. Write somewhere and remember. We also may do technetium scanning, and we also may do positron emission tomography test. So make a screenshot of this one, how it would look like. This scanning with technetium accumulated the parathyroid gland, as thyroid gland is sensitive to this radioactive medication, and it accumulates this drug in its tissues after scanning the size of tumors and activity of the tumors. But the best of the best, of course, is a SPECT, systemic B single proton emission computer tomography. It's a very good type of examination for various types of tumors. Now it becomes more and more popular, especially in oncology, in searching of various malignancies, metastases, and in endocrinology, this type of examination, emission tomography, positron emission tomography, also become very popular. For parathyroid disorders, we use systemic B single. That is the name of the drug. Well, actually, maybe you may not remember the name of the drugs which we use in positron emission tomography, but remember that this name of that examination, PET, positron emission tomography, we will use it in many endocrine disorders, especially in endocrine disorders with the tumors. So next topic will be Cushing syndrome. There we also will use it. So advantages, it is, first of all, it is non-invasion. It is, so it is really high sensitive, but it is expensive. Unfortunately, it is expensive and needs some time for preparation. So ultrasound examination, as I said, it's possible to do ultrasound, but it is less sensitive than previous to examination. Could be false negative if patient has some thyroid nodules, but possible to understand that is the ultrasound of parathyroid nodule. If a doctor who provides ultrasound is a highly experienced doctor, he may or she may do this ultrasound very successful. MRI, what it will give us? MRI, we also can do magnetic resonance imaging, localization of tumors, no radiation. Of course, this is the advantage, but sometimes could be also false positive if there are nodules in thyroid glands or in lymph nodes. So what we can do, PIH, so primary options. First, drugs, calcium mimetic drugs, calcium mimetics, only one drug is here, it decreases both serum calcium and PTH level because it blocks calcium receptors and imitates PTH activity, but without influence on the calcium resorption. So cinacalcet is an effective drug which can decrease symptoms of hyperparathyroidism, but it does not decrease size of the tumors, unfortunately. We use it as a primary prevention for surgery. Then people who have complications of hyperparathyroidism and have classic symptoms, kidney stones, bone resorption, mental changes, muscle changes, they should do parathyroidectomy. I mean, not this, of course, surgeries should provide hyperparathyroidectomy. It is a shortly, you see, treatment is much shorter than diagnosis. Mostly you need to understand diagnosis of parathyroid, of hyperparathyroidism. As I said, it will be briefly, but I hope that you will read the information which I will send you on Google Disk. Do you have questions in hyperparathyroidism? Do you listen to me anymore? Parathyroid disease, parathyroid gland produce more parathyroid hormone. Is it clear?
Yes,
Yes, ma'am. Well, we'll see how it is clear in your practical classes. Opposite condition is called hypopara. According to the name, parathyroid gland produce less parathyroid hormone. It is an uncommon condition. It is a rare disease. I saw in my practice maybe 5 or 10 patients with that disease because among other endocrine disorders, it's one of the rarest diseases. This is the situation when parathyroid gland produce less PTH. Hypoparathyroidism characterized by low level of PTH, everything which that process which should happen with the help of PTH decreased. So low level of PTH, low calcium resorption from the bones, decrease of phosphorus resorption, phosphorus oxide, of course, and decrease of calcium reabsorption, increase of alpha-1 alpha hydroxylase, decrease of calcium absorption in GAT. Look at the right part of the screen. Everything finally will provoke decrease of calcium and increasing of phosphorus level in blood. Parathyroid gland. From the left side, you see normal regulation. Once again, parathyroid hormone, kidney bone regulation, no parathyroid hormone, no regulation, no elevation of calcium. Calcium will dramatically decrease. It's classified on 3 big groups: acquired, transient, and congenital. Acquired means chronic. It's a chronic condition due to the destruction or deficiency of PTH due to autoimmune diseases. Transient could present if it is some infection for few periods, a few months or sometimes few weeks. Congenital, usually it is also transient, but may present in babies who are born too soon, for example, premature. Hypoparathyroidism may present due to the genetic disorders. Sees how many genetic disorders. Autoimmune disease. In childhood, if you see hypoparathyroidism in childs, it is autoimmune usually. If you see hypoparathyroidism in adults, usually it is post-surgical or post-ablative. So hypoparathyroidism in adults, the most common cause is a post-surgical damage of parathyroid glands. When it may happen? Post-thyroid surgery, thyroid gland surgery. If you provide thyroid gland surgery, you should be very careful and should not remove parathyroid glands. They are very small, sometimes are not possible to see them by eye, and sometimes doctors mistakenly remove parathyroid glands. Clinical symptoms here, opposite to previous condition, include, first of all, muscle cramps. It's the most dangerous and most classical symptom in hypoparathyroidism. Low calcium provoke formation of cramps everywhere, laryngeal or bronchospasm, diaphragma spasm, intracostal muscle spasm, GIT muscle spasm, peripheral muscle skeletal spasm, everywhere spasm. If it is a severe situation, low level of calcium, if it is very low level of calcium, we call this condition hypocalcemic crisis, and tetany, everywhere spasm. It was very dangerous. You understand, these people, they may die from heart and lung failure. Complications include reversible and irreversible complications. So reversible are tetany, convulsions, malformation of teeth and bones, impaired kidney function, heart arrhythmias. Irreversible, usually present if this condition develop in childhood, stunt growth, slow mental development in child, calcium deposition in brain, and cataracts. Tetany, as I said, is the most dangerous and most specific symptoms. How to diagnose? We have two symptoms. Please remember their names. They are called Chvostek sigh and Trousseau sigh. So positive Chvostek sigh. What does it mean? How to provide it? We tap face of the patient very gently in areas of fascial nerve, of 3 branches of fascial nerve in forehead and jaws. If there is muscle constriction, that is a classical symptom of hypoparathyroidism. It shows that there is a low hypocalcemia. Trousseau sigh. When you measure BP, you put a blood pressure cuff on the hand of the patient, compress it and wait for a few minutes. Carpospasm develop if there is hypocalcemia. It's called Trousseau sigh. Remember, please, them. How it look like? So carpopedal spasm and ECG changes in the patient with hypoparathyroidism. Then, how you will prove that it is hypopara? Of course, PTH test, it will be low. Serum calcium will be low. Phosphorus will be high. Vitamin D, here, it's not involved in pathogenesis. Creatinine, to understand what happened with the kidneys. In situation, if it is acute hypocalcemia, when it may develop very quickly, in a few minutes, when we remove parathyroid glands, we use calcium gluconate or calcium citrate IV. Here, calcium gluconate, very popular medication, IV, 10 to 20 minutes infusion. Then, we can use also, we should correct, of course, calcium concentration. And then after treatment by IV injections, we need to start oral calcium supplements in high dosage. Then we need to identify, of course, the cause, and to prevent hungry bone syndrome, vitamin D also recommended. So hypoparathyroidism nowadays we treat with the help of calcium and vitamin D. So our goals of treatments will be to remove muscle cramps, to control and to maintain serum calcium, the low or normal range, avoid hypercalciuria, and avoid elevation of calcium phosphate products. Here you see the medications which we used for chronic treatment of this disease. So calcium types, there are a lot of various types of calcium, any of it is okay, and vitamin D. Also vitamin D, better to use active form. D2 is more preferable, but if you don't have D2 in the market, also possible to use D3. Don't forget to, or if we see hypercalcemia, we also need to control magnesium level. In treatment of hypoparathyroidism, important also to treat hypomagnesemia. Typical dose for patient, you see also on the screen, 240 to 1000 mg, and need, of course, to control magnesium in the blood.